Good afternoon, my name is Crystal Dickerson.
Hi, I'm Holly Larson.
I'm Sriti Danthi.
Hello, I'm Helena Shfero.
Thank you. Judges, will you now please introduce yourselves with your name, academic degree, and positions?
Hi, my name is Carolina La Rosa Mateo. I have a master's in public health, and I'm the director of operations at a nonprofit called ACER.
Paul Gehring, I'm a psychiatrist, retired and now doing community mental health work.
My name is Kelly Webb. I have an MBA and an MHA. I work at Premier as a consultant with a focus in health equity.
Hi again. I'm Mickey Scullard. I work at the Minnesota Department of Health in Emergency Preparedness and Response. I have a DRPH and an MPH.
Thank you. Let me know when you're ready to begin and we'll start the timer.
Good afternoon again. So, any long-term care facility or any healthcare facility where patients are held for prolonged periods of time has to be vigilant about infection prevention and control. It's important to isolate patients from harmful substances, and especially long-term care facilities struggle with this, and we've seen this during the COVID pandemic, where long-term care facilities in Minnesota reported only 20% of the positive cases of COVID-19 compared to the community, but deaths from long-term care facilities contributed to 80% of the total deaths counted during COVID-19. So it shows us that how important it is to put forward plans that mitigate these strategies and protect the most vulnerable part of our population and make sure that the staff are protected as well. In our case scenario, we meet Dan, a registered nurse in St. Paul, Minnesota, and a single parent of 3. He's working in a long-term care facility amongst a pandemic with a novel influenza virus, and a 2-week mandatory quarantine has been put in place by the federal government to isolate incoming patients from the existing patients in the long-term care facility. And Dan is experiencing with his team PPE noncompliance. And in order to address these issues, conversations with the rest of his team are leading to distrust and tension within his team. He's also experiencing a limited supply of PPE as the long-term care facility he's working on has used most of their PPE supply during the COVID-19 pandemic. And there's differing points of view on how patients should be treated and what protocols should be put in place with regards to personal protective equipment. So how can we help Dan and every other long-term care facility staff like Dan avoid these problems and provide the utmost care for the residents? Our plan consists of putting together a multidisciplinary task force that directly reports to the incident command system put in place and that brings to the table all the stakeholders required to have the conversations that are needed to put together an equitable distribution of all resources and make sure that all long-term care facilities stick to the plan or protocols that are put in place. The task force will do this by implementing 2 major tasks, which have a communication and a resources part. So the task force will be put together through, by members of the Coalition of Long-Term Care Facility that represent Dan and other long-term care facility staff like Dan to make sure that all their concerns are heard. There will be a representative for residents and a representative for suppliers to make sure that personal protective equipment and vaccines, whenever they become available, are also represented in the task force. The task force will also have representatives from the Department of Health with expertise in professional development for providing continuous trainings on new coming information with regards to the pandemic to the long-term care facility staff, for infection prevention and control, and clinical care guideline development. There will also be specialists on equity and diversity to make sure that all long-term care facilities across Minnesota benefit equally from this task force. There will be a professional for communication to streamline all information coming into and going out from the task force and to make sure that those informations align with everybody. And a data management and a supply and logistics management specialists are also important to streamline this process. To equip the task force with up-to-date information and make sure that evidence-based decision-making is utilized, epidemiologists and public health specialists from the University of Minnesota should also be represented in this task force. How would this task force achieve this? This is a hierarchy of controls that lets us know whenever a hazardous substance like a virus or an infection is a threat, what measures should be put in place to minimize the damage from this harmful substance. The first step is elimination, which involves physically removing the harmful substance from the area, and the second place is replacing that harmful substance with something that's less harmful. The third step is engineering controls that are used to isolate patients or anybody from that hazardous substance. Unfortunately, these first three, even though the most effective ways, are not always possible in hospital care or long-term care setups. So we will hone in on administrative controls that change the way people work to streamline all the processes or all the guidelines that are put in place. We will now move on to the communication section of the plan, which will be presented by Sriti.
Thank you, Helena. In his long-term care facility, Dan is experiencing difficulty with PPE noncompliance, as well as distrust in his workplace. In order to combat this, the task force will implement the Integrated Health Platform, which will serve as a one-stop shop for public health updates, individual health updates, and staff and facility status. This platform will be integrated into the long-term care facility website to improve transparency, mitigate misinformation, and ensure that everyone is on the same page. In order to implement this, the task force will utilize the 3I initiative, the first component of which is information. The task force will organize targeted media campaigns through a community-wide initiative, which is targeted at the entire community, including facility staff like Dan and his coworkers. By first administering surveys, the task force would be able to assess misinformation, hesitancies, as well as inequities in the community. And then they can address them through community-driven discussion forums and free social media campaigns. During the pandemic, the information that is shared would be focused on pandemic-specific information. This would include information on vaccine availability, as well as the importance of PPE usage and social distancing. By also administering surveys throughout this process, the task force would be able to evaluate their performance and effectiveness in connecting people to health information in a centralized way. The second component of the 3I initiative focuses on internal infrastructure. First, the task force will ensure that each facility is equipped with adequate computers. Each computer will then be equipped with both resident-facing and staff-facing medical record platforms. These platforms will ensure that all members of the facility, residents and staff, are able to connect for a high level of quality care. Additionally, each computer will be equipped with free, secure video call interface, such as Zoom, so that residents can remain connected with other residents, with staff, as well as their families in the case of isolation. This utilization of Zoom will also ensure that facilities can save on PPE. The third and final component of the 3I initiative focuses on interpersonal and interfacility. The task force will attempt to address the distrust within the workplace, as seen in Dan's facility, by implementing a dashboard. This dashboard would include information on number of cases, PPE usage, as well as other important metrics to align the facility staff on the severity of the pandemic. Additionally, the Integrated Health Platform will house an online library of training videos that can be utilized by new and existing staff to keep themselves updated on protocol. Finally, the task force will utilize the Integrated Health Platform to organize team huddles. These team huddles would create a space where facility staff can come together, express concerns, and discuss protocol. This safe space would also help facility staff bring up any issues of equity that they are noticing amongst their resident population and then address them. This Integrated Health Platform works to create a safe and communicative workplace for all members of the facility. And now I will pass it off to Holly for the resources portion of our plan.
Thank you, Sriti. So I will be moving into the resources section of our plan. Coming back to this hierarchy of controls, this section of our plan hones in on this bottom triangle here in the access of personal protective equipment. So as we've discussed, Dan is facing at his long-term care facility shortages of PPE. And of course, this was a very widespread issue that we saw during the COVID-19 pandemic. Additionally, during the COVID-19 pandemic, a lot of facilities during times of crisis did not have the adequate resources or staffing to properly vet their suppliers, which at times led to low quality and even fraudulent PPE being purchased and distributed. So this is an issue that we are very aware of and want to address within this plan. So we are planning on creating a collaborative purchasing model at the state level to streamline the procurement of PPE and increase purchasing power. So this will start by creating a shared resource database. This will look like our task force reaching out to organizations throughout the state to ask who their trusted suppliers are, and creating a shared resource for other healthcare organizations to know who those suppliers are. Additionally, the task force will be doing basic vetting of these suppliers. This includes things like looking at pricing, product specifications, W-9 forms, and ensuring that their product is quality and up to standard. The task force will then implement an online questionnaire, which will serve the purpose of gathering interest and information from organizations who are looking to participate and aggregating volume. Resources will be purchased and then distributed through a hub and spoke model where centralized hubs exist and resources are further distributed to various spokes. The task force will work with local representatives from the Department of Health to ensure that these hub and spokes are in appropriate locations, and also to ensure that in more rural and underserved areas of the state, they get access to these distribution centers and that they're part of this collaborative purchasing. So as part of this collaborative purchasing plan, we recommend a strategic partnership with PPE Exchange, which is an online marketplace for PPE. So this will look like our task force doing their own supplier vetting, and the PPE Exchange platform will contact these suppliers, ensure that they have adequate inventory for these bulk purchases, and access that discounted bulk pricing. Then each organization is able to easily log on to PPE Exchange, create their account, and choose how they want to pay. So overall, our task force is doing the supplier research and vetting. PPE Exchange provides the platform for the purchasing and distribution, and this really increases purchasing power for those smaller facilities who aren't able to do their own supplier vetting and purchasing during high crisis times. Lastly, I will pass it off to Crystal.
Thank you so much, Holly. Now I'll talk a little bit about the cost and funding of our plan. In order to establish the cost of our PPE purchasing collaborative, we considered a model available from the state of North Carolina, in which the North Carolina Healthcare Association was able to negotiate the administrative fees with the PPE Exchange down to $0. We believe that our task force can create a similar arrangement for the state of Minnesota. In considering the cost for our 3I communications plan, we considered the elements listed here on the screen. In total, they amount to approximately $3.37 million. Finally, we understand the importance of compensating task force members for their time. Combined with the cost of surveys, our task force will cost us approximately $800,000. The total cost for all long-term care facilities throughout the state of Minnesota is $4.36 million. We intend to fund this plan through savings realized from our bulk purchasing from our PPE collaborative, through funding from the Minnesota Department of Health and Emergency Operations Center, through the Minnesota Omnibus Bill, which provides for workforce and training, and finally through federal grants. To measure the success of our communication plan, we'll look directly to our pre- and post-implementation surveys. There we expect to see increased compliance, increased staff satisfaction, and decreased vaccine hesitancy. For our resources plan, we'll look at our PPE stock levels. We will see decreases in PPE shortages, increase in product satisfaction, and increase in equity, as all facilities across the state of Minnesota will have access to our purchasing plan. The overall goal is to reduce the administrative burden on long-term care facilities so that individuals like Dan can focus on the care of our most vulnerable population. Our plan will begin in April of 2024, when our task force is formed and our pre-implementation surveys are issued so that we can assess attitudes about long-term care facilities. Approximately 6 months later, we will collect and vet that list of resources and existing partnerships that are available throughout the state. This means that our task force is poised at the beginning of the new year to release a list of shared supplier resources. Approximately 1 year from today, our task force will have established trust, collaboration, and communication with long-term care facilities. In the case of an initial outbreak of a novel influenza virus, we expect long-term care facilities to look directly to our task force for guidance, and our task force will be prepared to provide it. Finally, when the vaccine is rolled out in November of 2025, our task force will reevaluate attitudes via our post-implementation survey. Throughout the course of our timeline, we'll do program evaluation and revision. We met Dan at the beginning of our presentation. Dan was suffering from distrust, lack of PPE compliance, limited PPE supply, and conflicting points of view on his team. Now we see Dan, and through the work of our task force, Dan has found improved trust amongst his team. There is increased adherence to PPE guidelines. There is a stable and consistent supply of PPE, and there are clear expectations for communication and trust. This concludes our presentation. We are the Minnesota Healthcare Consultants team, and we presented preparedness and navigation for disease emergency management in long-term care facilities. Thank you for your time, and we welcome the opportunity to answer your questions.